G'day, I'd like to let you know that Aussie Med Ed is sponsored by Tego. For most doctors, indemnity insurance is one of their biggest costs of practice. While many doctors are still with the same insurer they joined in medical school, many have made the switch to Tego and benefited from it. The team at Tego have told me that those new to private practice could qualify for 4 years of discounted premiums. To find out more about Tego, visit tego.com.au. That's tego.com.au. G'day and welcome to the Aussie Med Ed, the Australian medical education podcast, where we get to interview specialists in a variety of medical areas, asking their opinion on their certain conditions and obtaining their insight into how they diagnose and treat that condition. In these COVID times, it's a way of replacing the relaxed discussion around the hospital by allowing the listener to put forward questions to be answered or addressed on their behalf. I hope you enjoy the whole program and welcome once again to Aussie Med Ed. Once again, welcome back to Aussie Med Ed. It's been a few week delay while I've been busy with the examination process in Adelaide. It's great to have you back on board, and in this edition we get to interview Dr Paul Hollington, a colorectal surgeon from the Flinders Medical Centre. He's going to talk about his experience and approach to colorectal cancers. Not only will this information be useful for the general practitioner seeing a patient on a regular basis, but also for the medical student revising for their exams or preparing for their OSCE examination. I'm Gavin Nimon, an orthopaedic surgeon based in Adelaide in South Australia, and I'm the host of this podcast. I'd like to begin this podcast by acknowledging the traditional custodians of the land on which this podcast has been produced and pay my respects to the elders both past and present. Well, it gives me great pleasure now to introduce Paul Hollington, a very good friend of mine who I've known now since 1993, and he's a colorectal surgeon from Flinders Medical Centre. Paul's going to talk to us about colorectal cancers and the different types there are. Welcome, Paul Hollington.
Thank you, Gavin.
Yeah, it's great to have you on board.
So we're going to talk a little bit about bowel cancer, so cancer of the colon and the rectum, which is my area of interest.
That's right, yeah. We're going to start off with colorectal cancers, cancer of the bowel, colon and rectum, and basically start off with basically what types there are. I mean, is only one type of cancer, or are there various different types of colorectal cancers?
Essentially, they're all adenocarcinomas, so the vast majority of the one cell type arising from the mucosa of the colon and the rectum. There are some subtypes, mainly histological subtypes, but in general they're all adenocarcinomas and they are extremely common. So around 1 in 15 of the normal population will develop a bowel cancer at some stage in their lifetime. So that's up there with the most common cancers like lung cancer, prostate cancer in males and breast cancer in females. Overall, bowel cancer, the rankings do vary from time to time, but overall bowel cancer is about the second most common cancer if you exclude skin cancers.
Colorectal cancers affecting the colon, rectum, anal area. So same sort of cancer, or is the one around the anal verge is a bit different?
Yeah, anal cancers are different. I mean, the anal canal is divided into two parts, the lower half and the upper half. The lower part is non-carotenoizing squamous cell lining. So those cancers are basically squamous cell carcinomas. And then there's a transitional zone in the upper anal canal. So they can be either squamous cell carcinomas or adenocarcinomas or some other cell types that are a little bit less common. You can also get melanomas in the anal canal. But in general, anal canal cancers are squamous cell carcinomas, which is quite different from adenocarcinomas. They behave differently and are treated differently.
So the anal area is considered part of a skin cancer type of conditions?
Yeah. The lower half of the anal canal is basically a skin cancer. And if they're just outside the anal verge, then they're treated like skin cancers and just excised with a small margin of normal tissue, and that's all that's required. If they are within the anal canal, then generally they're sensitive to radiotherapy and treated with radiotherapy rather than surgery. Chemotherapy is added to the radiotherapy to sensitise those cancer cells to the radiotherapy.
But the more common types are in the colorectal canal, which are the adenocarcinomas, and they're really the one main type.
Yes, that's correct. So colon and rectal cancers are adenocarcinomas and are extremely common, whereas the squamous cell carcinomas and other anal canal cancers are less common.
And the common colorectal cancers, they have associations as well. I presume there's a familial incidence or genetic incidence as well?
Yeah, so we think that around 30% of bowel cancers are primarily due to a genetic influence and around 70% due to environmental exposure. Having said that, though, usually it's a combination of both, but certainly 30% of bowel cancers have some sort of family history. Around 25% might have one or two relatives. They might be distant relatives and they might not be young relatives, but a small proportion, about 5% of bowel cancers, are due to inherited familial conditions such as adenomatous polyposis coli or hereditary non-polyposis colorectal cancer, with the latter being much more common than the APC. But apart from that 5% group, around another quarter of people who have bowel cancer will have a family history. So it's thought they're inheriting some sort of genetic susceptibility, but the exact nature of which genes are involved isn't clear in that setting. Otherwise, it's mainly environmental exposure, and the strongest associations are with a high fat and low fibre diet. So they're the main factors. Other things like smoking and alcohol have a small influence. Charred red meat or highly processed meat can also contribute to bowel cancer, but in general, it's relative lack of fibre in our Western style diet, and also relatively high fat content that is thought to contribute to bowel cancer.
So the processed meat that has an association with cancer, is it because of the large fat content in it, or is it because of maybe preservatives?
It's hard to tease out those factors. For example, is there an association with red meat in general, but that might be because of the fat content. So basically, a healthy diet for bowel cancer is to have a low fat and high fibre diet. It's also associated with things like sedentary lifestyle, so with obesity and low exercise rate. There's some increasing evidence that aspirin is protective against developing bowel cancer, and it's certainly now recommended for higher risk individuals, such as those with a polyposis syndrome or very strong family history. But there's probably evidence just in general that aspirin is protective for all bowel cancers.
What's the postulated thought for that? Is it a matter of keeping the blood vessels open to help circulation in the area, or is there any thought to what might occur?
No, it's probably related to the anti-inflammatory effect directly. So that does affect the process of development of these cancers. So basically, the majority of bowel cancers develop via the adenoma-carcinoma sequence, which is where very small polyps develop. And then over time, they accumulate sequentially genetic mutations, and through clonal expansions and further mutations, they become more advanced. So they get bigger and more advanced histologically before they finally become invasive. So it's called the adenoma-carcinoma sequence. And that accounts for most bowel cancers. The aspirin probably affects some of those mutations or the effects of those mutations, but it's not exactly known why aspirin is protective.
That's brilliant. It's interesting that it's actually another factor for the use of aspirin. You're saying about other causes or other associations as well.
For example, chronic inflammation. I mean, long-standing significant inflammation is a risk factor for malignancy anywhere, and that applies to the bowel as well. So patients with inflammatory bowel disease such as Crohn's disease or ulcerative colitis are at increased risk of getting bowel cancer, and that's not necessarily via that adenoma-carcinoma sequence. It can be by different pathways, and it's related to the amount of bowel that's involved and the length of time. So generally, patients with colitis that are involving the whole colon for at least 7 or 8 years would then start to get an increased risk of developing bowel cancer. And those patients undergo surveillance for that reason by colonoscopy.
Thanks, excellent, Paul. Thanks very much. We're going on to how all these cancers might present. How do they actually tend to present?
Well, the tumours often sit there without causing any symptoms, and that adenoma-carcinoma sequence in general is thought to take about 10 years. It can be shorter than that, but through observational studies, people that have refused surgery, for example, we know that from the earliest small polyp to when a cancer actually presents with symptoms or is discovered is often about 10 years. And so they can sit there for a long period of time because they don't actually cause symptoms. But some of the more common symptoms, patients do get symptoms, and that might be because the tumour's progressed and is quite large or advanced, and therefore eventually they do start causing some symptoms. They're often related to bleeding. For example, bleeding PR can be a sign of a bowel cancer, or anemia because the bleeding is often occult. But other symptoms include change of bowel habit or pain, for example, if a tumour is starting to cause obstruction or has an inflammatory response associated with it, then pain can result. So there's a number of different presentations. Basically, any bowel symptom really that's new and sustained needs further investigation. And the gold standard for investigation is to perform a colonoscopy.
Now, the students obviously will be presented in exams with acute abdomens. Would a bowel cancer be on the differential for an acute abdomen, or they don't present that way?
They can, but it's less likely. They grow slowly, so essentially it's a chronic, slow process. A tumour which is causing a lot of inflammation can present with localised peritonism, for example, or of course a tumour can perforate and then present with an acute abdomen, or perhaps a localised abscess, for example. That's less common than other presentation, and the patient presenting with an acute abdomen would more likely have some other cause. Bowel cancers can also cause obstruction, so presentation with an acute bowel obstruction can be a sign of a bowel cancer.
The question always comes to my mind is, obviously it's the way to investigate a colorectal cancer, I presume, is with colonoscopy, but are we just lucky we don't get too many cancers in the small bowel, or are there cancers that we just don't hear about?
It's a different lining, the mucosa, and it's not, in general, it's not susceptible to malignant change. So small bowel cancers are extremely uncommon, and large bowel, as in colon and or rectum, is extremely common to develop cancer. In general, the only situation where small bowel cancer occurs is in the setting, again, of chronic inflammation. Celiac disease is a good example of that. So where there's uncontrolled inflammation, so celiac disease with poor control, as in some exposure to gluten, can eventually result in small bowel cancer. Crohn's disease in the small bowel, of course, can cause small bowel cancer, but again, it's extremely uncommon. Small bowel cancers tend to have a very poor prognosis, but we don't see them very often. Another cause of small bowel cancer is the inherited condition I mentioned before, polyposis coli. They tend to get duodenal adenomas, and they can progress to cancers, but that's an underlying genetic abnormality, and it's very uncommon.
Is polyposis coli associated with a particular gene sequence that we know of, and is there a special test for that?
Well, it is the APC gene. You can undergo genetic testing for it if there's a suspicion, but generally these patients are known through their family history. They either go early genetic testing to see whether they've inherited the mutation, or they undergo surveillance at a very, very young age to see if they're developing polyps. So as a teenager, they start having flexible sigmoidoscopies just to see if they've inherited the phenotype. It's more likely for patients to have hereditary non-polyposis colorectal cancer. But both of these conditions can occur sporadically as well, so you can be the first person in the family to get it. Yeah, certainly if there's a risk, then they're referred to the genetics service for formal genetic testing.
And there's no viral association as well with these genetic mutations at all, or for the sporadic cases?
No, there is with the squamous cell carcinomas of the anal canal, but not with the bowel cancers.
And going on to investigations, I presume basically the main treatment is colonoscopy, or investigation is colonoscopy, is it? Or are there any other investigations you might do? Or
anyone that has a suspicion of bowel cancer, the gold standard is to perform a colonoscopy if they're fit and healthy enough to undergo the procedure, and any further treatments might be required. So, and the reason for that is it's extremely accurate. We get a very good view, and it picks up 98% of bowel cancers, and it's a very low-risk procedure. It is invasive, of course, and it enables us to get a tissue diagnosis, so to take biopsies of the tumour to confirm what it is, because there might be a differential. For example, an inflammatory mass can also look like a cancer, so it's important to get that tissue diagnosis. And colonoscopy also has the advantage of being able to remove precancerous lesions, so the polyps. So it can be a therapeutic as well as a diagnostic procedure. And then if the cancer is identified, then there are various other investigations that are required for staging of the tumour. Also, we use fecal occult blood tests, or FIT testing, fecal immunological tests, but that's purely for screening and not for investigation. So obviously screening is formed in an asymptomatic normal risk population. not patients with symptoms or who are higher risk. And by higher risk, I mean people with a family history of significant, or patients who have had polyps themselves that were precancerous, or had a cancer in the past that was treated. In fact, they have an extremely high risk of developing a second cancer.
Right. Because of a field change, I presume.
We don't really know, but presumably it's because of a genetic susceptibility. The fecal occult blood test is not used as an investigation, but it's used for screening, and that's what we use in Australia, and it's very effective at picking up bowel cancers and reducing your risk of dying from bowel cancer significantly. So if you have a positive fecal occult blood test, which is positive, then 50% of patients will have a polyp, and the whole idea is to pick up the polyps before they have the cancers so they can be removed at colonoscopy. If there is a bowel cancer in place already, it isn't 100% perfect at picking it up. It has about a 75% sensitivity for picking up a bowel cancer, and a bit less for polyps, which is why there are only polyps in about 50% of people. The other 50% are probably occult bleeding from internal hemorrhoids.
So the recommendation is for the low-risk patient to have a fecal occult hemoglobin every couple of years after 50, is it? Or
yeah, every 1 to 2 years between the age of 50 and 75. Some countries screen at a slightly younger age. There is some benefit in that. Older than 75, then patients tend to have higher false positive rate, and also they're less fit to undergo investigation and treatment. They tend to have more comorbidities. So that's who we currently screen in Australia at the moment. But if the colonoscopy has picked up a tumour, then we perform other staging investigations. And I guess staging, there are a couple of types of staging in bowel cancer. One is preoperative radiological staging, because that's done to guide treatment, but also there's post-operative clinico-pathological staging. And that gives us advice about prognosis and also determines the need for adjuvant therapies. And it's clinico-pathological because it incorporates the finding at surgery. For example, you might detect small liver metastases that are not obvious by other means, and also the histopathology of the resected specimen. So the treatment for bowel cancer is resectional surgery. That's what cures bowel cancer. And so that involves removing a segment of bowel and the draining lymph node basin, and then we look at that under the microscope to give us that staging information that determines prognosis and any further treatment.
The preoperative investigations that you said, the radiological, which ones are they? CT scans or?
Yeah, so bowel cancers metastasise to lymph nodes, also to the liver. The liver, if there are distant metastases, then the most solid organs, the most common site is the liver, and that's because the venous drainage of the bowel is via the portal system through the liver, so it's acting as a big filter. But also the second most common site is the lung, which I guess is also a big filter. And so we stage using a CT scan of the chest, abdomen and pelvis, and that's usually all that we need, unless it's a tumour within the pelvis, so the middle or the low rectum, and in that situation an MRI scan of the pelvis is useful to help determine management of rectal cancers, which can be a little bit more complex than colon cancers.
And once you've done that, then you proceed to a surgical resection, and I presume you clear some lymph nodes with it as well, do you, or just purely take the bowel at the time, depending on the size? I'd like to let you know that Aussie Med Ed is supported by HealthShare. HealthShare is a digital health company that provides solutions for patients, GPs and specialists across Australia. Two of HealthShare's core products are Better Consult, a pre-consultation questionnaire that allows GPs to know a patient's agenda before the consult begins, with the aim to reduce admin and free up time during a consult, and HealthShare's Specialist Referral Directory, a specialist and allied health directory integrated into GP practice management software, helping GPs find the right specialist. You can find out more from healthshare.com.au.
So the idea is to take out the segment of bowel containing the tumour so that there's a good resection margin, and usually in the colon the minimum margin of normal tissue that we like is 2 centimetres. It can be a bit less in the rectum, but in general we'd say it's 2 centimetres. And taking out that segment of bowel also involves removal of all of the lymph nodes within the draining basin, so the vascular supply of that particular segment of the bowel. And so taking those out allows us to stage it accurately. We like to get as many nodes as possible, and then prognosis is determined by whether they're involved with tumour or not. Well, the most common operations would be a right hemicolectomy, where we're removing often about a third of the colon on the right-hand side of the abdomen. That's supplied by the main blood supply is the ileocolic artery. So we divide that close to its origin from the superior mesenteric artery, and that enables us to take out all of the lymph glands that drain that particular part of the bowel and therefore the tumour. And another very common bowel cancer operation is called an anterior resection, and that's for a tumour of the left colon or the rectum.
Excellent. And you still stage using the TNM type classification system?
There's TNM or Dukes. So the Duke staging system is older and it's really stood the test of time. It's a very simple staging system, but it's reliable and it's still used today. Basically, that looks at how deeply the tumour has invaded in relation to the bowel wall, and also whether lymph glands or distant organs are involved. So, for example, a Dukes A tumour is one that's confined to the bowel wall, and that has a 95% 5-year survival. And Dukes B is where the tumour has penetrated through the bowel wall into the tissue just outside the bowel wall, but no further. That also has a very good prognosis, about 80% 5-year survival. And then if lymph glands are involved, then we call that Dukes C. And if distant organs are involved, such as the liver, then that's Dukes D. That has the poorest prognosis, probably about a 10% 5-year survival. These tumours are very curable. Around 70% of bowel cancers are cured with surgery, which is very high compared to other tumours, especially other tumours of the gastrointestinal tract and other solid organ tumours. If these tumours relapse, it usually occurs within about 3 years. And so patients make it to 5 years, because we generally quote 5-year survival, then we equate that with cure. The caveat is that if patients have had some sort of adjuvant therapy, such as radiotherapy or chemotherapy, that can actually delay relapse. And so 5 years might not be long enough in that setting. But if patients haven't had chemotherapy, for example, and they make it to 5 years, then we generally say they're cured of their bowel cancer.
When would you use adjuvant therapy? Is that just for Dukes D, or is that any other time as well?
In general, it's used for Dukes C because it's obviously a toxic treatment with risks, including mortality risk, but it's been shown to improve patient survival significantly. Probably overall an additional 10% survival gain if you have chemotherapy in Dukes C, i.e. if the lymph nodes are involved. Another setting of chemotherapy would be for palliation. If a patient has inoperable metastatic disease, and that's another situation where we might use it. It's not an adjuvant therapy, obviously, in that setting. It's a palliative treatment. We sometimes use neoadjuvant therapy, but that's reserved for low rectal cancers, which have a high risk of local recurrence. And also there are other advantages to being able to use radiotherapy in that position. For example, the colon is a mobile structure and surrounded by other radiosensitive organs, such as the small bowel, whereas the extraperitoneal component of the rectum, so the low rectum, is a fixed area that can be targeted very precisely by radiotherapy. So we sometimes use chemoradiotherapy. Again, chemotherapy sensitises the tumour cells to the radiotherapy. So we sometimes use that in a low rectal cancer if we deem that the risk of local recurrence is high.
Well, that's a good point, actually. Once the cancer has been diagnosed and treated, what about the long-term follow-up? What's required and how do you do it?
There is a relatively high risk of relapse. As I said, it often occurs early, but relapse is potentially treatable in these patients if it's detected early. And in fact, it can sometimes be cured. And so these patients generally undergo a very intensive surveillance program early on after their surgery and or chemotherapy. And that involves regular clinical review, regular radiological investigation, sometimes blood tests such as CEA, and also regular clinical review. And these things occur more frequently early on, and then as the patient, depending on their outcome, but if they're doing well and there's no sign of relapse, then the interval between surveillance investigations increases. And in fact, the only one that should be done lifelong in terms of if the patient's fit and healthy would be colonoscopy. Because that is not to detect relapse, but it's to prevent metachronous cancers developing. As I said before, these patients are at very high risk of growing new polyps, which can turn into metachronous cancers if left. So we do regular colonoscopies following bowel cancer surgery.
So how often would they be?
The guidelines vary a little bit. At the moment, in general, we will do one a year after surgery, and then usually every 5 years, depending on the findings. If they do have polyps or colonoscopy, then that can influence the subsequent surveillance interval. But yeah, generally, after an initial early one, it's usually every 5 years.
You said radiological investigations for following up. Would that be a CT of the chest, abdomen and pelvis again?
Exactly, and as I said, the risk of relapse is higher within the first 2 or 3 years. So we generally do a CT at the first year and then every 12 months for 3 or 4 years. If it's a Dukes A cancer, so the Dukes A patients have only a 5% risk of relapse. So if they get to 5 years, they don't need ongoing CT scans. Whereas if a patient's had chemotherapy for Dukes C cancer, then it might be, if they're fit and young, it might be that we'd keep going despite the regular radiation dose from the CT scan, that would keep going for a few years. So it's really got to be tailored to the patient's age and fitness and the risk of relapse. But in general, most patients would have a CT scan perhaps at 1, 2 and 3 years after bowel cancer, sometimes longer.
Excellent. Actually, I realised we did touch upon it just then, CEA, the role of CEA in bowel cancer.
CEA is widely used. It actually has a high false positive and false negative rate. Not all bowel cancer surgeons use CEA for that reason. So it's a fairly blunt instrument, but its surveillance is often part of a package, and it's just one component that might or might not be helpful. In the last few years, there's been worked on other circulating tumour markers that are looking very promising and I think will be of much better value than CEA. But certainly CEA is currently widely used, but perhaps not as good a test for picking up relapse as the CT scan.
And is TNM still used at all? Obviously, you rely on Dukes.
We use both, absolutely. The TNM is a little bit more complicated. For example, in the rectum, the T stage is subdivided based on depth of invasion. For example, for a T3 lesion which has gone beyond the muscularis propria, it's then subdivided to A, B, C, D, depending on how many millimetres of invasion there are, because that helps determine whether radiotherapy is needed before surgery for a low rectal cancer, for example. So TNM can be a little bit more complicated. But in general, these cancers are reported synoptically by the pathologist, and so there's a lot of standardised aspects that are reported on. In general, they would give us a TNM stage. Most people would still use the Dukes just for ease of use, and sometimes pathologists will give us both.
Look, thank you very much, Paul. You've covered so much area in colorectal cancer. Really appreciate the summary and review of this area, and I think the students listening to it will really appreciate it. Once again, I'd like to thank you very much for coming on Aussie Med Ed. Thank you very much, Dr. Paul Hollington.
No worries. Thank you. Thanks, Gavin.
The information provided to you today is designed to complement the information provided to you in your local region and should supplement your readings and teachings in that area. Please don't take it as the only way of treating this condition or assessing a condition, but really as one of various ways of assessing these conditions. Please also be aware that the information provided today is really just general medical advice and isn't designed to actually be a source of medical information regarding your particular condition. Remember to consult your specialist or medical practitioner if you have concerns about a condition raised in this podcast. Thanks once again for listening to our podcast, Aussie Med Ed, or the Australian Medical Education Podcast. We really enjoy hosting this podcast. I hope you find it useful to hear a pragmatic approach to everyday conditions. If you have any questions or information you want to ask about us, or you'd like to put a suggestion for a topic, please don't hesitate to email us at gavin@med-ed.com.au. Once again, I hope you've enjoyed listening to it, and we look forward to hosting it next fortnight when we introduce a new topic. Thank you. Aussie Med Ed is proudly sponsored by HealthShare, a digital health company that provides solutions for patients, GPs and specialists across Australia, and Tego, offering medical indemnity insurance for doctors. That's tego.com.au.